is Ozempic good for people with PCOS?
This is the best question. I love this question. This is the best question.
And
Take
honestly,
it away.
I will take credit for PCOS and Ozempic.
Take it.
So I will, because I started using these meds for my PCOS patients in 2014. Number one, it regulates your insulin. Number two, it affects your appetite, right? People feel full. And that's why if you're going to have a surgery, if you're going to have a procedure that requires sedation, you have to stop these GLP-1 medications 2 weeks prior to your procedure because of that delayed gastric emptying. We don't want people to aspirate when we put them to sleep. But otherwise, they're very safe. I've literally used these medications for 10 years. I've never seen anything complicated or bad with it.
Wow. Is there with the GLP-1s, is there like an amount of time people should be on it, or is it like a?
That's a very good question. So if you're a PCOS patient who's morbidly obese, right, and you need to lose 100 pounds, and I have those patients that have lost like 100 pounds with me, those patients can almost never come off of it, right? Because obesity is multifactorial. It's not just insulin resistance. Sure. So a lot of times when these patients respond to it, it's great. Some of them need to stay on it for a lifetime. I have family members who've been on it since 2014, and it's fine.
Yeah.
And but other patients who there's sometimes, even I use it now for insulin resistant menopausal patients. They gain 25 pounds and they're killing themselves and they can't lose the weight. So I give it to them. When they get to their weight, I take them off. And honestly, as a side note, this OV powder that I created for insulin resistance would work great for anyone with insulin resistance.
Yeah.
Do you know what I'm saying? Because it's anti-inflammatory, it has antioxidants, it can regulate hormones, it can regulate the blood sugar. So any of these women can also be on it.
Yeah.
And it does not interfere with any medication. So I think it's a great addition to these patients' routine. But to answer your question again, and to be clear, some patients need to stay on it for the rest of their life, and that's fine. And others can get to their goal, come off of it, and start maintaining it with diet and exercise.
It's going to be interesting because I feel like when you start looking at all the research right now with these GLP-1s, and they're saying they're geoprotective. There's a lot of geoprotective for your brain, for your heart, like all of these things that are coming out. And they're saying that dementia is type 3 diabetes. It's you have too much, insulin or whatever that is, you're insulin resistant in your brain. My question to you, and I've meant to ask you this, do you think that is because that they are truly geoprotective? So it would be geoprotective for you or I, or is it geoprotective for so many people that were morbidly obese that were taking it and now they've lost all this weight, and of course their brain's going to function better, their heart's going to function better?
I don't think we know the answer to that. I think we need more studies. There's so many studies, but personally, what I've seen, it makes a difference. Let me tell you, for example, you have someone who drinks a lot of alcohol, right? Alcohol is not good for you. You have someone who's smoking a lot. You give them these medications and it takes all their cravings away. I have patients who come and say, I used to pick my skin all day and I stopped doing it. I used to bite my nails and I don't do it anymore. So I think we've seen so many benefits with these meds. And I've honestly, I know doctors there are patients who get pancreatitis from it. There are patients who have ileus from it. But I think if it's done right and prescribed correctly, then it can really, really help patients who are overweight, especially obese. It's been a game changer in my practice. And like I said, I have 10 years of experience. The problem is I feel like even now, doctors don't know how to prescribe it.
Well, and we still need a lot more research.
Right.
I mean, we're going to, thank God so many people are on it that we're going to have a lot of data.
Learn.
And there are different types of medications, how fast you go up, where you start, which medication you choose. Like if you have someone who needs to lose 100 pounds, you have to start with one type of medication and then switch them to the other. It's not just one size fits all formula for everyone.
Wow.
But there was something that just came out today. I just saw an article where the compounded, because a lot of it's compounded, and I think that's going to be taken away.
Well, you don't want to use compounded medication when when a medication is on the FDA's shortage list. You can technically go to compounded medications. The problem with compounded medications, especially GLP-1s, you don't know where the ingredients are coming from. Each pharmacy is mixing their own. You have to draw it out of a bottle. So it works, and it has helped a lot of people who could not afford these medications. And, the problem right now is with these insurance companies, they're making it extremely difficult for patients to have access to these medications. So if you're someone who needs to lose 100 pounds and you really need the medication, right?
Yeah.
And your insurance is still denying it, then you don't have another choice but to go to these compounded medication, which is really, really sad. Part of it is the insurance companies are adding, and here's what I will say, because November is open enrollment. If you're overweight and obese, please call your insurance company. Make sure they don't drop your obesity benefits. If they drop your obesity benefits, then what's going to happen is come January 1st, you're going to call and your prescription won't get covered. And sometimes they drop you without you knowing.
I didn't even know that was a thing.
I didn't either.
Oh, of course, you need to have the benefits. So what happened a couple of years ago, they dropped a lot of people.
Wow.
So patients who really need these medications, they need to call their insurance companies if they don't have these benefits, pay for it and add it.
Yeah.
The other thing I would say is for patients who don't really need it, if you need to lose 5 pounds, please don't grab these medications from pharmacies because they're overweight and obese patients who really need it. We define overweight with a BMI of 27 or more, and obesity is with a BMI of 30 or more. Yeah. So these prescriptions should be covered for these patients. And I will add one last thing is that if you don't have insurance, your insurance doesn't cover it, there are coupons now available for some of these medications.
Oh, wow.
That, patients can use. I think the length of that coupon right now, as we speak, is about 6 months. So after 6 months, you can't use the coupon. But with the coupon, it's about 50% off, but it's still expensive. I mean, we're talking about $650 a month.
Yeah.
Which is, it's really hard to afford these meds.
Yeah.
And, these meds should be available publicly. To these patients, especially the obese patients. It's because it's a game changer for them.
Yeah. That's crazy how needed it is. I didn't realize that at all. When someone mentioned it to me, I was like, wait, what? That correlates?
But for the very, obviously,
sure.
because
sure.
otherwise it's the OV powder or it's the metformin or, there are things to do if you're, even slightly overweight,
Yeah. Do you think that reason for it going undiagnosed is just because doctors don't know, or is it just...
I think we don't get enough training, just like the resident I was telling you about. I've said this for many years. OB and GYN, obstetrics and gynecology, should be separated. You should have doctors delivering babies all day long, and then you need gynecologists. What happens right now is doctors are doing both, right?
Yeah.
I did that for years. And you
still
burn
do
out.
that.
Not like before. I used to do at some point 80 deliveries a month by myself.
Wow.
And so imagine 30 days in a month, I was doing 80 deliveries a month. A lot of them were in the middle of the night, and I had a full-time clinic. And these patients, when I was accepting insurance, I had maybe 10, 15 minutes with each patient.
Yeah.
You cannot possibly correctly diagnose, treat. You can diagnose someone in 1 minute, but to educate them and to prescribe the medication and explain to the patient why they need to do it. So that's one limiting factor. The second one is doctors, patients, nurses, nurse practitioners are not educated enough about these two conditions.
Yeah.
And the third one is doctors don't have time.